I'm Joe Graydon.
And I'm Terry Graydon. Welcome to this podcast of the People's Pharmacy.
You can find previous podcasts and more information on a range of health topics at peoplespharmacy.com. Fewer Americans are dying of heart attacks these days, but cardiovascular disease is still our number one killer. This is the People's Pharmacy with Terry and Joe Graydon.
We'll take a fresh look at blood pressure, cholesterol, calcium, and other risk factors for heart disease. Have you had a coronary artery calcium scan?
Do you know what your blood pressure is? Was the measurement done properly? It's surprisingly easy to make mistakes.
Inflammation plays a significant role in heart disease. Could an anti-inflammatory drug usually prescribed for gout be helpful?
Coming up on the People's Pharmacy, Beyond Cholesterol, Rethinking Your Risk of Heart Disease.
In the People's Pharmacy Health Headlines. For a long time, American parents were careful to protect their infants from peanut-containing products for fear of triggering a potentially lethal allergy. Nevertheless, peanut allergies continued to rise. Then in 2015, a carefully conducted scientific study showed that infants introduced to small amounts of peanuts between 4 and 6 months were less likely to react badly to them. Pediatricians changed their recommendations after that. Now, a study of health records of children under 3 shows that the rate of peanut allergies has dropped pretty dramatically, from 0.8% in 2012 to 0.5% in 2019. That may not sound like much, but it is statistically significant and represents a 43% reduction in relative risk. Pediatricians are still cautious about advising parents on feeding peanut butter to babies who seem likely to develop allergies. But fewer peanut allergies could definitely make life less stressful for many youngsters and their families.
Researchers have been arguing about how many steps you need to prevent cardiovascular disease. For years, we were told that 10,000 steps should be the goal. Then, scientists reported that 7,000 might be enough for older adults. Now, a new study in the Annals of Internal Medicine reports that getting your steps in a single long walk is better for cardiovascular health than accumulating steps in many shorter walks. The investigators analyzed data from more than 33,000 participants in the UK Biobank database. These healthy people averaged 62 years of age at the start of the review and were taking fewer than 8,000 steps daily. The periods of physical activity were classified as shorter than 5 minutes, 5 to 10 minutes, 10 to 15 minutes, or 15 minutes or longer. After 8 years, the volunteers who regularly walked more than 15 minutes at a time were 80% less likely to have died. They were 70% less likely to have a heart attack or stroke than the people who took shorter walks. 4.4% of people who took very short walks died during the 10 years of follow-up. Fewer than 1% of those taking long walks died during that time. The authors conclude that when people get most of their daily steps from longer walks, they do better.
Some people like to sleep in total darkness, while others prefer to keep a nightlight on so they can see the path to the bathroom if they need to use it. A study of health records from the UK Biobank covered more than 88,000 people over nearly 10 years. The participants wore light sensors on their wrists for a week near the start of the study. Researchers compared outcomes for people with dark nights to those for people with the brightest nights. People exposed to bright light at night were significantly more likely to develop coronary artery disease, heart attacks, heart failure, atrial fibrillation, and stroke. Increased light exposure boosted the risk for women more than for men. The investigators recommend avoiding light at night.
It's estimated that nearly 400 million people suffer from knee osteoarthritis worldwide. Exercise is considered a cornerstone of knee osteoarthritis management, but what exercise is helpful and won't damage sore joints? A new study randomized patients with knee arthritis to receive either online information about the benefits of exercise for arthritis or a Tai Chi program with a mobile app encouraging adherence to this kind of gentle exercise. The investigators report that this randomized clinical trial found that this unsupervised multimodal online Tai Chi intervention improved knee pain and function compared with control at 12 weeks.
Irritable bowel syndrome can make life very uncomfortable. People often request dietary advice and they're told to avoid foods that bacteria can ferment, the so-called low FODMAP diet. Now, scientists report that following a Mediterranean diet, which is easier, offers just as much relief. And that's the health news from the People's Pharmacy this week. Welcome to the People's Pharmacy. I'm Terry Graydon.
And I'm Joe Graydon. Heart disease has been our number one killer for decades. We've got dozens of highly effective drugs to lower cholesterol. What else should we be doing to overcome this widespread threat to public health, beyond simply swallowing a pill?
Today, we'll be discussing ways for you to reduce the likelihood that you'll have a heart attack or other serious heart problem. What should you know about keeping your heart healthy?
Our guest today is an expert in preventing heart problems. To find out how you can reduce your risk of heart disease, we turn to Dr. Michael Blaha. He's professor of cardiology and epidemiology at Johns Hopkins School of Medicine. Dr. Blaha is the director of clinical research for the Johns Hopkins Ciccarone Center for the Prevention of Cardiovascular Disease. Clinically, Dr. Blaha practices as a preventive cardiologist and in the interpretation of cardiac CT. He's received multiple grant awards from the National Institutes of Health, the FDA, and the American Heart Association.
Welcome back to the People's Pharmacy. Dr. Michael Blaha.
Yeah, thanks for having me back.
Dr. Blaha, the American Heart Association just recently reported that heart disease is still the number one killer in America. And that's after almost 40 years of statins and all kinds of other cholesterol-lowering drugs. Atorvastatin is the most prescribed drug in America. It's big number one at 30 million Americans taking that medication. What else should we be doing to reduce our risk of having a heart attack or other cardiovascular diseases like stroke?
Well, there's no doubt we've made tremendous progress over the last several decades, 3 to 4 decades, really driven by smoking reductions, more attention to blood pressure, as you mentioned, cholesterol reduction, both from diet, reduction in trans fats, but as well as statins. But of course, residual risk remains. And as you mentioned, atherosclerotic cardiovascular disease remains the number one killer, really close to cancer now. In fact, some states, cancer is higher than ASCVD, than atherosclerotic cardiovascular disease. But in general, atherosclerotic cardiovascular disease remains the number one killer. And really, the epidemic now is one of metabolic disease, driven by obesity and diabetes. Those are the risk factors that we have not yet had as big of a breakthrough on. So while statins are helpful, blood pressure reduction is helpful, of course, what we've learned about diet and exercise, we still need to do more about obesity and diabetes.
Has Ozempic and Wegovy and Mounjaro and Zepbound, the GLP-1 agonists, changed the equation? There are a lot of people who say, wow, it's like a miracle.
Yeah, they've completely changed the equation. It's probably the biggest breakthrough statins as far as pharmacologic prevention goes. Yes, we've never been able to have meaningful weight loss in the office before with the diet and exercise strategy that's consistent or with the drug. Now that we've learned more about the behavior of hormones from the gut and the way they interact with the brain, and we've shifted the thinking around obesity towards one of a chronic disease rather than just a willpower problem. We understand some of the brain chemistry. It's unlocked the ability to make meaningful weight loss. So these therapies can induce significant weight loss, significant fat cell reduction, fat mass reduction. They're anti-inflammatory. And they have cardiovascular benefits, but also benefits on the liver, on sleep, and other things. So we've started to make progress in this regard. Of course, we need to still work on diet and exercise and how that fits in with these GLP-1 and the next generation of incretin-based therapies. But absolutely, the future is bright as far as treating obesity, but we need to prevent it in the first place too.
When it comes to heart disease, there's another risk factor that we will soon be able to treat with medications. I don't think that the FDA has approved any of these medicines yet, but pharmaceutical firms are working on drugs that will lower LP little a. Is that going to make a difference?
Yeah, I hope so. So, a quick primer on lipoprotein A. So, this is a cholesterol carrying moiety that when you measure your LDL cholesterol, it's hidden within that LDL cholesterol measurement. To actually get your LP little a levels, your lipoprotein A levels, you need to also measure it directly in the bloodstream. And it's a measure really of genetic cholesterol risk. Your levels are 90% determined by your genetics. So it's not much that you can do about it as far as diet and exercise goes. You inherit it from your family. And it is causal in causing atherosclerotic cardiovascular disease. And it's the explanation of some of the heart disease that we see that happens in patients with no other risk factors. But this, hiding behind the normal lipid profile, the lipoprotein A levels. About 1 in 5 patients in the world has an elevated lipoprotein A level. It can be higher in certain populations like South Asians, for example. So it's common, it's genetic, and it's not treatable right now. And it's a cause of, once again, some, not all, but some of the unexplained heart disease that we see.
Well, hang on a sec, Dr. Blaha. 20%, 1 out of 5. That's a lot.
It is a lot. Yeah, there's no doubt about it. About 4 out of 5 patients have very low levels, but 1 in 5 can have extraordinarily high levels. And once again, you don't know it unless you measure it. And as you mentioned, many pharmaceutical companies are working on therapies that do indeed successfully lower lipoprotein A levels. But we won't know until next year if those therapies actually reduce cardiovascular risk. We'll know soon, though.
You know, we have talked to Dr. Tsimikas, who has been studying LP little a for quite a long time. And he actually wrote I would say, a somewhat controversial article in one of the heart journals, An Inconvenient Truth Regarding Statins, in the statins raise LP little a, not a whole lot, but a little bit. And so I've always been a little confused. It seems like you're driving with your foot on the brake and the gas simultaneously if you're trying to reduce your risk of heart disease, but a statin is raising your LP little a levels. Your thoughts?
Yeah, it's true. These processes are quite complicated. So both LPA lowering drugs, and it looks like many anti-inflammatory drugs can raise your LDL a little bit. This just goes to show the interconnection between inflammation, lipoprotein A, and LDL, for example. So it's true. Now, the good thing is the statins lower the LDL way more than the LPA lowering drugs raise the LDL. And still, clearly, there's a net benefit, hopefully, of both of these drug classes. But we're going to have to understand how all these things interact. So, once again, we'll have to wait for the trials, and we'll know as soon as next year if these drugs lower cardiovascular risk despite raising LDL a little bit. Now, all of these studies of the LPA drugs are in patients taking statins.
Right. I've got another question before the break, and it has to do with another class of drugs called beta blockers. They're among the most prescribed drugs in America. There was a Nobel Prize to
Black, I believe.
Dr. Black. He developed the first one, propranolol, but there's a whole bunch of others. Metoprolol. There's atenolol. There's carvedilol. There are lots
Sotalol.
lots
There's
of
lots
beta
of
blockers.
olols.
And, there was a time, I'm sure, that you absolutely prescribed the beta blocker for just about everybody who had a heart attack. And that was like, if you don't prescribe a beta blocker after someone has a heart attack, that would be considered malpractice.
Yeah.
The New England Journal of Medicine has just added to the literature that suggests if people have good heart function after a heart attack, and you'll have to explain ejection fraction, that maybe a beta blocker is not such a great idea after all. Some patients will benefit if their hearts are damaged severely, but others not so much. Could you give us a quick 2-minute overview?
Sure. Yeah, the beta blockers are absolutely important drugs. They reduce the autonomic nervous system stress on the heart, let's call it. They reduce the impact of some pathomimetics, the neurotransmitters that stimulate the heart, so they relax the heart.
You're talking about the fight or flight reaction, the adrenaline reaction.
Yeah, they start to blunt that, which helps to reduce the stress on the heart, which certainly is good, generally speaking, after a heart attack. But the way it turns out is these drugs really exert their effect by reducing that stress on the heart and reducing the subsequent risk of heart failure or ventricular arrhythmias after a heart attack. And those predominantly occur in people with substantial damage to the heart tissue. So if you've had a heart attack and your heart function is reduced, your ejection fraction, your heart squeeze is reduced, you're at risk for heart failure and ventricular arrhythmias, and the beta blockers probably have a role there. In fact, they definitely have a role there. But there's a lot of patients nowadays who have small heart attacks treated very well with a stent and other medicines, and they do extremely well. And they're not really at risk for heart failure or arrhythmias, at least in the short term. And it turns out after a short course of beta blockers, these patients probably don't need to stay on beta blockers long term because they're not at high risk of heart failure and not at high risk of arrhythmias. And beta blockers can have side effects. So really after maybe a year of a beta blocker, in the chronic phase of atherosclerotic cardiovascular disease, we probably don't need beta blockers in most patients who have normal heart squeeze, normal heart function.
You're listening to Dr. Michael Blaha, professor of cardiology and epidemiology at the Johns Hopkins School of Medicine. He's the director of clinical research for the Johns Hopkins Ciccarone Center for the Prevention of Cardiovascular Disease.
After the break, we'll talk about blood pressure. It's an important risk factor, but how low should it go?
Sometimes when blood pressure medicines work too well, people may get faint and fall when they stand up from sitting or lying down.
Blood pressure measurement can be trickier than it seems. Is the clinic doing it correctly? Do you have white coat hypertension?
Find out about the best technique for blood pressure measurement. Is your arm supported?
Is the clinic using the right size cuff?
New machines have the guidelines built in.
The AHA recently introduced a new risk calculator. Why does it matter?
You're listening to The People's Pharmacy with Joe and Terry Graydon. Welcome back to The People's Pharmacy. I'm Terry Graydon.
And I'm Joe Graydon. The People's Pharmacy is brought to you in part by Sonu, an FDA-approved drug-free treatment for nasal congestion and runny nose, using sound instead of steroids. More at getsonu.com. That's getsonu.com.
Today we're talking about how to reduce your chances of developing heart disease. One important risk factor is blood pressure. The CDC estimates that nearly half of all American adults have hypertension. That's about 120 million people. Are you one of them?
To learn more about preventing heart disease, we turn back to Dr. Michael Blaha, professor of cardiology and epidemiology at Johns Hopkins School of Medicine. He's the director of clinical research for the Johns Hopkins Ciccarone Center for the Prevention of Cardiovascular Disease. Clinically, Dr. Blaha practices as a preventive cardiologist and in the interpretation of cardiac CT.
Dr. Blaha, we know that one of the risk factors that we're always reminded we need to keep under control is blood pressure. And we can ask, and probably will, about the various levels of blood pressure and exactly what is a really good blood pressure at. Does it vary from one age to another? But what I'd like to ask you about right now is balancing blood pressure control against the potential side effect of someone feeling dizzy, especially there's something that doctors call orthostatic hypotension. And what it amounts to is a person on such a medication stands up from sitting or from lying down, and they just basically fall over. They get faint, and that clearly is not a desirable situation. Can you tell us a bit, please, about how a doctor and patient can work together to balance these risks?
Yeah, you bring up a really important point. And one of the long-standing debates in cardiovascular disease is what's the best blood pressure. And clearly, we've decided that the higher your risk of atherosclerotic cardiovascular disease, the lower your blood pressure be, or the tighter your blood pressure control should be. And we're really looking for, in our high-risk patients, normalization of the blood pressure. This reduces cognitive problems later on, reduces heart failure and heart disease risk over time, but it does come with side effects. Blood pressure drugs do blunt autoregulation of the blood pressure. As you mentioned, when you stand, part of that autoregulatory response is blunted, and you can get dizzy. You can get low blood pressure when you stand. And this is something that we are always working with our patients. It's something we talk to our patients about when they start blood pressure drugs. It's something we talk about when we set aggressive blood pressure goals. And it's a common reason we have to back off on blood pressure therapy too. So you're right. We need to talk to our patients about what our blood pressure goal will be. If your risk is not so high, your blood pressure can be more lenient. If your risk of cardiovascular disease is high, we need to be very aggressive with the blood pressure and really need to talk about potential for orthostatic hypotension. We do tend to avoid the beta blockers for blood pressure. They're not really good antihypertensive drugs. They're a fourth or fifth line choice. They can cause orthostatic hypotension, but really any blood pressure drug can cause orthostatic hypotension. So it's part of the discussion, and it's part of the complex juggling act, as you mentioned, between getting the lowest blood pressure we can to reduce your risk while balancing side effects. And some patients are just going to have to deal with a little bit of orthostatic hypotension, which means when you rise from standing, you wait for a moment before you walk. You rise from standing a little slower, you maintain hydration. And this is some of the give and the take of everyday blood pressure management.
Dr. Blaha, I'd like to talk about blood pressure measurement for a minute.
Measurement rather than management.
Exactly. Because we get a lot of messages on our website from people who say, holy cow, I've seen the American Heart Association's guidelines. These are people who are really dedicated to getting their blood pressure correct, and they're taking their blood pressure at home and following the guidelines. But when I go to the clinic, the first thing that happens is I'm stuck in traffic, and I'm almost always getting late, and I'm always feeling rushed, and I'm always a little anxious. And then as soon as I get taken back from the waiting room, the technician or the nurse, they immediately take my blood pressure. I don't get to relax. I don't get to go to the bathroom. And they sometimes put me on the exam table, and my legs are dangling and my arm is dangling, and they're talking to me. And all of those things mess my blood pressure up. I have this thing called white coat hypertension anyway, and that just makes it worse. And so my blood pressure may be 150 or 160 over 95 in the doctor's office, but as soon as I get home, it's back around 120 over 80. So Can you share with us the correct way to have a blood pressure taken when you're at a clinic?
Yeah, this is an enormously important question because blood pressures commonly aren't checked well in the clinic, and it's the result of a busy practice. Really, it takes a lot of time to make a good blood pressure measurement. And a quick segue to saying this is why we find home blood pressures from patients extraordinarily important. We always want our patients checking their blood pressure at home and bringing in a home blood pressure log. But when you come to the office, the ideal way of checking the blood pressure is being put in a quiet room, sitting down, waiting for 3 to 5 minutes before anything is done in this quiet room, and then using an automated blood pressure cuff with your feet on the ground and your arm at the heart level, so elevated but at the level of your heart, and checking that blood pressure probably in duplicate, and checking for consistency of that blood pressure across two measurements and either averaging them or taking the latter of the two measurements. And honestly, in most patients or in many patients with hypertension, we should be checking that blood pressure in both arms. Now, the reality is we can't do this in every busy practice. That alone will take 10 minutes. But we should be doing it more often than we are now. But what we should also be doing is encouraging all of our patients to take these high quality blood pressure measurements at home too. You check it at home, you can check it with less stress, you can check it in that quiet situation, you can check it at the same time every day. So they're more comparable measurements compared to the random blood pressure that you get in the office. And the reality is the physician, the patient should be making decisions based on all of the above information. The blood pressure in the clinic and the blood pressure at home and the blood pressures throughout the day, whether it be morning, night, or afternoon. All of these add up to what your true blood pressure really is. And in my clinic, I'm routinely making blood pressure decisions with a combination of all these data points. One single blood pressure measurement in the office is insufficient to characterize someone's blood pressure trajectory.
I think that's really important for people to know. And there are a couple of other questions or issues about blood pressure measurement that I'd like us to touch on. When I take my blood pressure at home, Dr. Blaha, I have a piece of furniture nearby that supports my arm at exactly the level of my heart or close enough. When it's taken in the clinic, the last time I had my blood pressure taken at my doctor's office, the nurse just had me hold my arm out. It was not supported at all. What difference does that make?
Yeah, these probably make small differences, but all of these little elements that we talk about add up to potentially making big differences. If you talk about supporting your arm, if you talk about resting, if you talk about feet on the floor, all these can add up to substantial blood pressure variation. So you're hitting at really important points. And I think we both want to measure the blood pressure well, but we also want to measure it consistently. Mm-hmm. So when we compare measurements from visit to visit or morning to afternoon or day to day, we're measuring it the same way each time. That can be as important as doing the blood pressure in the perfect way. But you're absolutely right. Feet on the ground, arms supported at the level of the heart is the ideal way to measure the blood pressure.
And one other thing I could do at home is make sure my blood pressure cuff is the right size. If my arm is super skinny or extra fat, I can get a cuff that is adjusted to my arm size. In the clinic, they're much less likely to change those cuffs when a patient has a non-standard size arm.
Yeah, absolutely. Another critically important point. Arm size varies tremendously. We try to change the cuff as much as we can in practice. We try to supplement this with a manual blood pressure check, but we can't do it in reality in every situation. But blood pressure cuff size is another extremely important variable. Blood pressure is extremely hard to measure. I think we consider it sometimes as one number, but really it needs to be averaged. It's the area under the curve, so to speak, of your blood pressure over your entire week, your entire month, your entire lifetime that matters the most.
You know what really drives me a little crazy, Dr. Blaha? The new blood pressure machines have built into them what I'll call the guideline targets. And every once in a while, if I take my blood pressure and it shows up at, let's just say, 121/79, which I think, yeah, that's pretty good. It says stage 1 hypertension. And I go, whoa, that's just not fair. Come on, guys. But it's like if you're not below 120 over 80, you get dinged. What's the deal with that?
Hmm. Well, you raise an important point about these normal values. It's the same thing on your lab slip when it shows your LDL cholesterol being too low, or maybe your LDL cholesterol too high when it's actually fine for your risk level. Tricky. These things are tricky. Yeah, I prefer probably if it didn't say something like stage 1 hypertension, it just said you're in the yellow zone, perhaps not the green zone on that measurement. But yes, it gets to the main point that it's really about the integration of many blood pressure checks. If you check it again and you don't have stage 1 hypertension anymore, of course, you don't indeed have a clinical diagnosis. You just had one blood pressure measurement that was high. So, yeah, I think we could probably use different terminology there. I like the color coding of blood pressure measurements. You had a yellow, or I'm consistently in the yellow. I'm certainly not want to be in the red. But you're right. We can't be making diagnoses based on one measurement. We never do that.
Let's switch gears a bit and talk about blood pressure medications. The number one blood pressure pill in America is lisinopril. It's what we call an ACE inhibitor, angiotensin converting enzyme inhibitor. These were originally derived from the jararaca snake in Brazil, if I'm not mistaken. I think captopril was the very first one. And they are extraordinarily effective, and most people do really well on them, but there are some side effects. So tell us about the lisinopril cough. And I have to tell you, we have heard from people who say, oh man, I went to my doctor, I got lisinopril. 6 weeks later, I started coughing my head off, and then I was referred to an allergist, and then I had to go see an asthma expert, and I was taking all these other drugs for the cough when it was really the lisinopril. So tell us about that cough, and then tell us about something called angioedema. Rare, but potentially deadly.
Yeah, the ACE inhibitors are a good class of medications for blood pressure. They reduce the blood pressure, they protect the kidneys, they can protect the heart, they reduce cardiovascular events when you lower the blood pressure using them. But like any medicine, they have side effects. And the number one side effect with the ACE inhibitors, besides hypotension, besides low blood pressure, can be this cough. Turns out the way that these drugs influence metabolism of hormones in the body, they do increase a moiety called bradykinin. This can cause cough. So this is well known that it can cause cough. And I don't know, 5 to 10% of patients, probably in my experience, can develop a cough. It can be subtle, as you mentioned. It's not obvious. It doesn't pop up the first dose you take the pill. It can be subtle and a very kind of a light cough that gets misinterpreted as other things. It doesn't get connected with the ACE inhibitor always because it doesn't always pop up on that first or second dose. It usually goes away when you switch to a different blood pressure class of drugs like an angiotensin receptor blocker or another class of medications. But yeah, this is something we should think about when we give our patients ACE inhibitors. Now, in some patients, you can get a more extreme reaction, almost like an allergic reaction called angioedema, where you don't just get a cough, but you actually get swelling of the face, hands. You can even get swelling of the airway, which can be a high risk. Occurs more often in Black patients than other race ethnic groups. This is something to be aware of, and it's one of the reasons why most of us, for blood pressure at least, select an ARB, an ARB, instead of an ACE inhibitor as the first choice. But both of them are similar and both great blood pressure drugs. But like any drug, it doesn't come free. It always comes with some risk of side effects. And low blood pressure and cough and rare risk of angioedema is the thing to be worried about when you start an ACE inhibitor like lisinopril.
Dr. Blaha, you've mentioned a couple times that the patient's overall risk has an impact on the selection of intervention. And I think that recently that risk calculator has been updated. Can you tell us briefly about that, please?
Yes, risk is the number one concept in preventive medicine. We want to make sure all of our therapies are selected based on risk. We don't want to overtreat low-risk people. We want to treat our patients that are high risk more aggressively. So risk is everything, but risk can be hard to estimate. We start with doing something called a risk calculator, as you mentioned. And the most recent one is called the Prevent Risk Calculator. Prevent, Prevent, like prevent. And this calculates the 10-year risk of both atherosclerotic cardiovascular disease or total cardiovascular disease, including heart failure. And there's also an option of including a measurement for 30-year risk. And it's really using traditional risk factors that we measure in the clinic, but also can add in the hemoglobin A1C, the urine albuminuria. Also includes your zip code. It can include your zip code because it turns out where you live influences your risk. And it takes race, ethnicity out of the equation that was in prior equations. And it calculates your 10-year risk. Now, honestly, the prevent equations aren't that different than our prior set of equations, the pooled cohort equations. But for some patients, they can be more accurate. But most importantly, they don't overestimate the risk like our prior calculators do. This one is better, what we call calibrated, so that the risk estimates actually numerically match what we observe in the real world better. That's the biggest innovation with the Prevent Risk Score. It's a better calibrated risk score, and it's now recommended across all the ACC, AHA guidelines.
You're listening to Dr. Michael Blaha, Professor of Cardiology and Epidemiology at the Johns Hopkins School of Medicine. He's the Director of Clinical Research for the Johns Hopkins Ciccarone Center for the Prevention of Cardiovascular Disease. Clinically, Dr. Blaha practices as a preventive cardiologist and in the interpretation of cardiac CT. Dr. Blaha has received multiple grant awards from the National Institutes of Health, the FDA, the American Heart Association, the Amgen Foundation, and the Aetna Foundation.
After the break, we're going to talk about a different risk factor for heart disease, coronary artery calcium score, or CAC.
What is it, and why is it important?
You can see calcium on a scan, but should you worry more about the plaques with calcium or the goo inside the lining of the arteries?
What should we all be doing to reduce our risk of heart disease?
What lessons should we take from people who have heart attacks, even though they've seemingly done everything right?
You're listening to The People's Pharmacy with Joe and Terry Graydon.
Welcome back to the People's Pharmacy. I'm Joe Graydon.
And I'm Terry Graydon. The People's Pharmacy is brought to you in part by Sonu, an FDA-approved drug-free treatment for nasal congestion and runny nose, using sound instead of steroids. More at getsonu.com. That's getsonu.com.
Most people have had blood tests to determine their total cholesterol, their LDL cholesterol, their HDL cholesterol, and triglycerides. Some have even had a test for lipoprotein A, or Lp(a).
Others may have had a CAC scan. That stands for coronary artery calcium, and it shows up on a CT scan of the heart. What does a CAC score tell you about the health of your heart?
To find out, we're talking with Dr. Michael Blaha. He's professor of cardiology and epidemiology at Johns Hopkins School of Medicine. He's the director of the clinical research for the Johns Hopkins Ciccarone Center for the Prevention of Cardiovascular Disease. Clinically, Dr. Blaha practices as a preventive cardiologist and in the interpretation of cardiac CT.
Dr. Blaha, one of the factors that we are sometimes hear recommended to help us determine our risk is the calcium, coronary artery calcium, the CAC score.
Right.
Can you tell us what is it? And is it important?
Yeah, the calcium score is super important. It's guideline recommended now across the world. In fact, new guidelines are embracing it more than ever before. And what it is, it's a simple, rapid CT scan of the heart. It's so-called gated to the cardiac cycle. In other words, you put electrodes on your chest, so it takes the pictures only during part of your heart cycle when the heart's in between pumping, so you can get a still image of the heart, even though your heart is active. And that picture of the heart reveals the heart anatomy, but it also reveals calcium within the heart because calcium stands out on x-rays or on CT scans. It stands out, it's easy to see. So on these heart scans, we look for calcium deposits within the coronary arteries because we know that as plaque in the arteries ages, it becomes calcified. So if we see calcium within the coronary arteries on one of these simple rapid CT scans, we know that you have plaque in the arteries. In fact, the more calcium you have, the more plaque you have in the arteries. So effectively, this is a simple test for how much plaque you have in your arteries. The calcium score is a plaque burden test for the heart.
Who needs a calcium artery score? Who needs
Yeah.
to undergo this test? Because I'm assuming it's not appropriate for everyone.
Yeah, it's not appropriate for everyone. It really needs to be done in the setting of risk assessment. I mean, if you don't need your risk further assessed, you're either a very low risk patient or you're already a very high risk patient that's being treated aggressively. You don't need this test. This is a great test for initial risk assessment as we're deciding on both the initiation or intensity of preventive therapies or even the intensity of lifestyle recommendations. So it's a great way to figure out your personalized risk. The risk scores that we talked about give a population risk estimate. If there was 1,000 patients like you, what percent of them would develop disease? This is a test actually of your arteries. So it tells you in your body, in your arteries, how much plaque do you have? In other words, all of those risk elements, risk factors, how do they impact your arteries? So it's really a personalized risk assessment of you, of how much plaque you have in your arteries. And it's appropriate for patients who are either borderline to intermediate risk with one of these risk scores, where they're in the middle, so to speak. It's appropriate for patients who have so-called risk-enhancing factors, factors that aren't accounted for in these risk scores, but are common, like family history, South Asian ancestry, the metabolic syndrome, chronic kidney disease, inflammatory disorders like rheumatoid arthritis, elevated lipoprotein A, which we talked about earlier, all risk-enhancing factors that indicate a calcium score could be helpful. Calcium score can also be helpful in patients who are uncertain about therapy. Let's say that the risk score says they probably should be on therapy, but they're uncertain. They say, well, I don't know. I want to get a better assessment of my risk and how likely I am to benefit. That's a great reason. Calcium score can also be motivating. It can change a patient's perspective on their lifestyle and maybe motivate lifestyle change. That's actually a good reason for a calcium score too. So whenever it might change your lifestyle, change your treatment decisions, change the intensity of treatment decisions, that could be cholesterol, that could be aspirin, blood pressure, and the risk is uncertain, it's indicated. And currently in the guidelines, there's a so-called class 2A recommendation for these patients to get a calcium score. That means it's favorable to do a calcium score, but it's not mandatory. So just as you mentioned, it should be part of the physician-patient risk discussion. And if a patient says, I don't want to take a medicine regardless of my risk, they don't need a calcium score. But the more common scenario is a patient says, I really want to know what my risk is, doc. How can I figure that out? And a calcium score is one of the best ways of doing
Now,
that.
Dr. Blaha, we spoke with a cardiologist several years ago who said, calcium carbonate, it's like chalk. It's hard. And yeah, it's in that artery plaque, but it's not that big a problem. The problem is in the softer tissue. And so it's like when the plaque fractures and that goo that's inside the coronary artery oozes out, that's what causes the clot. And he was making the case for, don't worry so much about the calcium in your arteries. It's the other stuff that's inflammatory. How would you respond to him?
Well, the good thing is I can counter that by citing international guidelines around the world that recommend the calcium score. So this is really a minority opinion, but actually there's a lot of truth to that too. it's true that it's the soft plaque or it's the partially calcified plaque that tends to rupture and cause heart attacks. So it's true that we don't fixate on the calcium so much, but we use calcium as a marker of your total plaque burden. You can't see soft plaque on a routine x-ray. You need a more sophisticated scan to see that. But you can see calcium on a simple scan. You can see it even on a chest CT that you get to rule out pneumonia. So we use calcium as a marker of your total plaque burden, realizing that we can't see the non-calcified plaque. But if you have calcified plaque, you have the non-calcified plaque too. We can guarantee you that. So yes, it's a good marker of risk. It's a good marker of your total plaque burden, but it shouldn't be fixated on the calcium isn't the problem. In other words, it's not like how much calcium you're eating in your diet, or I need to avoid drinking milk. That has nothing to do with it. The calcium is just a marker of your total plaque burden. It just happens to be the best marker, the most accessible and cheap marker that we can use in practice. That's why we use it, and that's why the guidelines recommend it.
Dr. Blaha, you have mentioned that one of the reasons that people might want to know their CAC score is so that they can adjust their lifestyle. And I'd really like to ask about lifestyle. What are the non-drug approaches we should all be doing to lower our risk of heart disease?
Great question. I like to think of lifestyle as a two-staged approach. There's certain things that everyone should be doing, right? Everyone should be eating a generally heart-healthy diet. Everyone should be getting appropriate amounts of physical activity. Everyone should be at least conducting some moderate to vigorous physical activity. This is something that everyone should be doing. Now, I recommend this to all of my patients regardless. But really, there's a second tier, so to speak, a second level of lifestyle intervention. Right? So if a patient comes to me and they get a calcium score done and it's very high, I'm going to sit them down and say, well, let's really revisit that lifestyle. Let's talk about specific ways of improving your lifestyle. Let's talk about going further. Let's dig into the diet and talk about specific additional changes you can make beyond the general heart healthy diet. Do we need to be moving more towards plant-based? Do we need to be removing more saturated fat from the diet? Do we need to be getting a physical trainer or a dietitian to look at you and figure out how to lower your risk? Do we need to increase your physical activity with a step counter or get some more feedback on your physical activity levels? Do you need to be increasing the soluble fiber in your diet, which can also lower the LDL? So I like to think of it as recommendations we make for everyone, and then in-depth, detailed recommendations we make for our high-risk patients. So yes, even lifestyle, we're going to cater to the risk of the patient. High-risk patients, we're going to do everything we can to dive into that lifestyle to make all the recommendations to improve that risk. Now, if a patient's low risk, we'll probably just stick with the basics. Heart-healthy diet, get your exercise, and just maintain that for life.
What I'd like to ask you about is very controversial, and it has to do with people who have done everything right. I can't tell you how many messages we get from people who say, I'm a vegetarian, or I eat very, very healthy food. I exercise, I walk, or I run on a regular basis. I don't smoke. I never have smoked. My cholesterol levels are fabulous, but I had a heart attack last year. How could that be? And when we've heard from other people who say, I've been taking statins for 30 years and I had a heart attack. Come on. That wasn't supposed to happen. And I guess, I think about James Fix, the runner who, had really cleaned up his lifestyle, and he was running and boom, he dropped dead of a heart attack almost instantly. And there are a lot of people who do experience what's called cardiac arrest with no, chest pain, no elephant on the chest, no jaw pain. Can you tell us about those, what I would call sudden onset heart attacks, where you can't get them to the emergency department in time, and theoretically they were doing everything right?
Yeah, these are really important. This is really the goal of the preventive cardiologist. I'm a preventive cardiologist, is to reduce these life-changing heart attacks that were so-called unexpected. Now, it turns out, of course, that many heart attacks are preceded by risk factors. But some heart attacks do occur in patients without risk factors, but patients almost never experience heart attacks like this if they have no plaque in their arteries. This is why we need to use, in most patients, both risk factors and an assessment of their plaque burden, like a calcium score, for example, for risk assessment. Because we'll see this. We've done studies in populations of people with no risk factors. And you know what? Some people still have highly elevated calcium scores. We've done calcium scores in groups of patients who have multiple risk factors. Some of them have no calcium in their arteries at all. The reality is at the individual patient level, it's still extremely complex. In complex environment, gene, risk factor interactions that lead to your vulnerability. And that's why we like to personalize that risk assessment with imaging. Now, there's even a few patients who will have events even without any plaque in their arteries, but that is rare. The combination of knowing your risk factors and knowing how much plaque is in your arteries will give us the best chance of preventing these sorts of heart attacks. In our population studies, when we follow patients up and find these patients who've died suddenly, nearly all of them had significant plaque in their arteries up to a decade or even 2 decades earlier.
Well, let me ask you about one other risk factor that cardiologists don't always talk about: infections. There are now a substantial number of studies that have demonstrated that upper respiratory tract infections like COVID or influenza or pneumonia or even other infections like, you might run into it with a urinary tract infection or periodontal disease where you have gum inflammation and infection. And the researchers say, well, it's an inflammatory reaction from the infection, and that kicks off a cascade of events that leads to heart attacks and even strokes. That's not something that cardiologists usually think about that they can do anything about, and preventing pneumonia or preventing the flu.
But there is some data suggesting that getting vaccinated against the flu or getting vaccinated against RSV can actually lower your risk for heart disease.
Dr. Blaha?
Yeah, you're speaking to really this kind of inflammatory hypothesis of cardiovascular disease, which is definitely maturing, and there's just no doubt about it that low-grade inflammation is a risk factor for heart disease. And I would say actually the paradigm of what you're talking about really comes from the HIV literature. Patients with HIV have an increased risk of cardiovascular disease, and that seems to be largely explained by low-grade inflammation. So HIV is considered a risk factor for heart disease now, and we will treat it with a statin in all cases of HIV, regardless of other risk factors, because we know those that HIV puts you at risk for cardiovascular disease. Now, it's harder to piece together these acute infections, like you mentioned, for example, a respiratory infection or kidney infection, but multiple acute infections probably do something similar to a chronic infection with something like HIV. Put it this way: inflammation, chronic inflammation, or multiple bouts of acute inflammation are not good for the body. They raise the risk of cardiovascular disease. So to make a quick segue there, of course, one of the next big generations of therapies that hopefully will come to fruition for cardiovascular disease are the specific targeted anti-inflammatory therapies that are under development right now.
I was hoping you'd say that. We only have a minute left. Can you give us a quick overview in about 30 seconds about your study of colchicine?
Well, colchicine is one of those, and there's multiple biologics on the way for inflammation. But yeah, colchicine is a drug that interacts with the so-called NLRP3 inflammasome. It's a kind of a organelle that forms in the body in response to stress and inflammation. And this chronic inflammation can be suppressed by colchicine, and you can lower your cardiovascular risk. You also lower your risk of gout and even your risk of needing a hip replacement or osteoarthritis. So it's linking together all this chronic wear and tear, this inflammation, and cardiovascular disease together. And there's many therapies beyond colchicine, which is great, coming for that might potentially be the next wave of new cardiovascular therapies.
Well, colchicine has been around for decades. It's been used for gout for a very long time, and it's cool that you've done some research showing it may be beneficial for cardiovascular disease as well. Dr. Blaha, I'd like to ask you about a category of medications that people pretty much take for granted. And I won't say everyone with high blood pressure gets put on a diuretic, but boy, a lot of people do. And they're often combined with drugs like lisinopril, for example, or as you mentioned earlier in the show, the ARBs. So we're talking about hydrochlorothiazide and other thiazides. There are several other kinds of diuretics as well. Um, the idea of sodium and potassium and other minerals which may be depleted, zinc, magnesium, when you take these diuretics, it's a very complicated story. And it's been our experience that not everybody gets monitored on a regular basis. They may see their doctor once a year, and they might get a blood test just before they see their doctor, but then they may go for 6 months or a year without getting checked for their, for example, potassium levels. And as a cardiologist, you are very much aware of what happens when potassium gets too low or too high. So tell us about diuretics and some of the possible side effects, including skin cancer.
Yeah, diuretics are an important part of blood pressure therapy because many times patients with high blood pressure have so-called volume expansion. They essentially have too much volume, too much pressure, water within the vasculature, and it needs to be depleted. And a diuretic, by inducing the kidney to essentially pee out water and salt, can decrease the blood pressure. But like anything, that can come with side effects, particularly patients who have kidney disease or patients who have pre-existing electrolyte disorders. You can either be depleted in your sodium, you can retain potassium depending on the diuretic we're talking about. All these things do need to be monitored. Usually those show up within the first several months of taking the therapy, but they can show up later too. They're generally safe. Millions of patients take diuretics safely, but it should be checked after you start one of these therapies. Your electrolytes should be checked and should be checked on a routine basis going forward with routine labs. Once again, all medications have side effects, and with diuretics, we need to be aware of the higher risk of electrolyte disorders. And with the hydrochlorothiazide, a rare instance of skin disorders can happen. That's also true.
Can you share with us what the symptoms of low potassium and high potassium would be? Because they're very similar.
Yeah, and most of the time we're talking about low grade reductions in potassium or elevations of potassium, which can be asymptomatic, but they can cause gastrointestinal problems. They can cause kind of neurologic problems or problems with sensation. They show up with things like changes on the electrocardiogram as well. But I think I really want to make the point here that low grade changes in your electrolytes are usually asymptomatic. So we can't rely on symptoms to tell us. We need to check our labs in patients on diuretics to make sure that these electrolytes aren't getting out of whack. There can be symptoms, but there can be no symptoms too.
Dr. Blaha, a lot of people have seen commercials for what I'll call home electrocardiograms. Without mentioning any brands, but even the phone, iPhones,
Yeah.
for example, can measure for something called atrial fibrillation.
Sure.
Why is it important to, number one, detect AFib, and B, what are the possible complications of AFib? And if you can, what can you as an interventional cardiologist do to prevent something bad happening if somebody does have AFib?
Yeah, so atrial fibrillation is the most common arrhythmia in older adults. It's when the top chamber of the heart starts beating irregularly, erratically. It's fibrillating. And in some patients can cause palpitations or rapid heart rate, but in a lot of patients, actually, atrial fibrillation is asymptomatic. We have to stress that. In many patients, atrial fibrillation is asymptomatic. Now, atrial fibrillation can cause blood clots in the heart and can cause, by virtue of those blood clots going to the brain, they can cause stroke. In fact, it's one of the largest risk factors for stroke. So this is a tricky situation. We have a very common arrhythmia that can be asymptomatic, but is associated with stroke, which is why we go out of our way to try to identify it. We're trying to find new ways of identifying atrial fibrillation in asymptomatic patients. But this is tricky too. So things like home EKG monitors can find atrial fibrillation. They can be extremely helpful in certain patients. But in other patients, they can lead to false positive results too. So we need to recognize all these home measurements are not as good as the EKG in the office. But many patients can show up and say, hey, I've seen atrial fibrillation on my home monitor. Let's check it out. I might need to be on a blood thinner. That's what we do. For patients with atrial fibrillation, they need to be on a blood thinner to reduce that risk of stroke. It dramatically reduces the risk of stroke. But of course, it doesn't reduce the risk of stroke if you don't know you have AFib and you're not taking a blood thinner. So early detection of AFib is very important. But there's caveats there. We don't routinely recommend low-risk patients check their heart rhythm at home. That's probably not useful. But if you're higher risk, or maybe you have some early palpitations, we do think it's a reasonable idea to come get an EKG or check your rhythm at home and share that with your doctor.
Dr. Blaha, can you tell us a little bit more about colchicine, this gout medicine that's been around for decades? What did you find?
Yeah, low-dose colchicine taken at a low dose in a chronic way, as opposed to the acute bouts of colchicine you take for gout, can suppress inflammation and appears to lower cardiovascular risk. One of the studies we've done most recently after the FDA approval of colchicine for cardiovascular risk reduction is to look to see how many patients are taking it. And it turns out colchicine has been very slowly uptaken by physicians. I think they're still trying to get their mind around this idea of an anti-inflammatory drug for cardiovascular disease, but it appears to work on top of things like a statin and blood pressure control. So low-dose colchicine is a good option for patients who have inflammation, high cardiovascular risk, and they want to reduce their risk further. Now, there's some side effects with colchicine too. Some patients get gastrointestinal upset. You can't take it if you have severe kidney disease. But for other patients, the low dose daily colchicine is a great way of lowering cardiovascular risk, but it's not being used much. We're still doing studies on it to understand it more. It's in the guidelines, it's FDA approved, but it's still so new that we're trying to get used to who benefits the most from this really exciting old therapy.
Dr. Blaha, we understand that the FDA has recently approved a blood pressure medicine in an entirely new category. What can you tell us about it?
Yeah, this is pretty exciting because we haven't had a new mechanism of action for blood pressure in a long time. So, particularly in patients with resistant hypertension who need the fourth or fifth drug, we didn't really have any new innovations. So, aprocitentan is a dual endothelin receptor antagonist. It blocks a mechanism in the body that raises blood pressure in a new way. And it lowers blood pressure even in patients taking 3 or 4 drugs who are still having elevated blood pressure. So really, it's a resistant hypertension drug, a brand new class when we're looking for new options. You can pick a drug like this, and we have another couple drugs coming down the pipeline for resistant hypertension. So patients who have a hard time getting to goal on multiple drugs didn't used to have many good options. They could lean on an old drug or they could try to change within classes, but they didn't have any new mechanisms of action. Now with aprocitentan or new drugs coming for aldosterone synthase inhibitors, they're going to have new options for resistant hypertension. So resistant hypertension is in a hot new area. We're going to have brand new options and new ways to get patients to goal.
Dr. Blaha, our listeners want to know what medicine you're talking about. Those generic names can be hard to pronounce and hard to spell. Is there a brand name associated with this new blood pressure pill?
Yes, absolutely. This drug that's a dual endothelin receptor antagonist is called Tryvio. Tryvio, Tryvio.
Tryvio.
Because you're going to try to get your blood pressure down.
Right.
I guess so. I guess we all need to get more experience with this brand new drug.
Dr. Michael Blaha, thank you so much for talking with us on the People's Pharmacy today.
My pleasure. Thanks for having me.
You've been listening to Dr. Michael Blaha. He is professor of cardiology and epidemiology at the Johns Hopkins School of Medicine. He's the director of clinical research for the Johns Hopkins Ciccarone Center for the Prevention of Cardiovascular Disease. Clinically, Dr. Blaha practices as a preventive cardiologist and in the interpretation of cardiac CT. Dr. Blaha has received multiple grant awards from the National Institutes of Health, the FDA, the American Heart Association, the Amgen Foundation, and the Aetna Foundation.
Lynn Siegel produced today's show. Al Wodarski engineered. Dave Graydon edits our interviews. B.J. Liederman composed our theme music.
This show is a co-production of North Carolina Public Radio, WUNC, with the People's Pharmacy.
Today's show is number 1450. You can find it online at peoplespharmacy.com. At peoplespharmacy.com, you can share your comments about this episode. You can also reach us through email, radio@peoplespharmacy.com.
Our interviews are available through your favorite podcast provider. You'll find the podcast on our website on Monday morning. In the podcast this week, there's some information that wouldn't fit in this broadcast. You'll hear about the pros and cons of diuretics, especially their impact on minerals like sodium and potassium. Can you detect AFib at home? And should you? We discuss the technology that could make this possible. We also get more details on the colchicine study, as well as the new drug FDA recently approved for hypertension. What makes it different from other blood pressure pills?
At peoplespharmacy.com, you can sign up for our free online newsletter to get the latest news about important health stories. When you subscribe, you also have regular access to information about our weekly podcast. And we'd be grateful if you would consider writing a review of the People's Pharmacy and posting it to the podcast platform you prefer. In Durham, North Carolina, I'm Joe Graydon.
And I'm Terry Graydon. Thank you for listening. Please join us again next week. Thank you for listening to the People's Pharmacy Podcast. It's an honor and a pleasure to bring you our award-winning program week in and week out. But producing and distributing this show as a free podcast takes time and costs money.
If you like what we do and you'd like to help us continue to produce high-quality, independent healthcare journalism, please consider chipping in.
All you have to do is go to peoplespharmacy.com/donate.
Whether it's just one time or a monthly donation, you can be part of the team that makes this show possible. Thank you for your continued loyalty and support. We couldn't make our show without you.